We will now go on to the last talk in the session, Anterior Ischemic Optic Neuropathy, When to Treat. Let me welcome Dr. Kiran KR, VR Surgeon at Trust Hospital, Talsheri. While he is getting ready, we are actually seeing an increasing number of patients who are presenting with diplopia who have concomitant squint, which is like just manifesting because of the increased shift from online to regular classes.
Third one.
There has been a lot of cases that are now coming. Not transient. In our investigation, we do not get anything. They are quite, but they seem to adopt some kind of compensatory head posture. But on examination, it looks like a incomitant.
Good evening. I'm Dr. Kiran and I'll be discussing anterior ischemic optic neuropathy. I would like to thank Dr. Rahana and KSOS for this opportunity. The blood supply of the optic nerve head is by the short posterior ciliary artery, and it forms a watershed zone that makes it very vulnerable for for ischemia, and it also has a segmental supply. The AON can be divided into arthritic and non-arthritic. Non-arthritic ischemic optic neuropathy is the most common acute optic neuropathy in patients over the age of 50. The pathophysiology is commonly hypoperfusion, though rarely occlusion through an emboli can occur. In the event of a hypoperfusion, there will be optic nerve ischemia, and when it is the crowded disc is a very important contributory factor for AON, non-arthritic AON. In a crowded disc, when there is an ischemia, it kind of forms a compartment syndrome where there will be axonal and capillary compression, which again worsens the ischemia, and with this ischemia will again in turn lead to vasogenic and cytotoxic disc edema, which forms a vicious cycle. There are a lot of systemic risk factors, nocturnal arterial hypertension being the most important, because most of the patients would complain of blurring on waking up. Other risk factors include diabetes, hypertension, ischemic heart disease, hyperlipidemia, atherosclerosis, sleep apnea, malignant arterial hypertension, migraine, aggressive hypertension treatment, and drugs such as sildenafil. And ocular risk factors include the condition that increases the crowding of the disc, such as small cup, optic disc drusen, any disc edema due to other causes, and other condition that affects the optic nerve perfusion, such as acute angle closure glaucoma. Usually patients present with acute painless unilateral loss of vision, most of them experience on waking up. There's no gender predilection. The mean age is around between 55 to 65 years. And the patient usually presents with a sectoral disc pallor, you can see in this picture, sectoral disc pallor, and there could be a sectoral disc edema associated with nerve fiber layer hemorrhages. And you can also notice the other eye, which has a very small cup and a crowded disc. And FFA would aid in the diagnosis, which will show a segmental delay in the filling in one quadrant, and you can also see a corresponding inferior altitudinal field effect. VP normally shows a decreased amplitude, which will help to differentiate it from optic neuritis, which would show a prolonged latency. Coming to the treatment, the treatment mainly focuses on controlling the risk factors. There is no effective treatment as such. Many treatments have been tried, such as optic nerve decompression, aspirin to avoid the NaON in the other eye, neuroprotective agents. There are studies on the steroid is one of the most commonly used, systemic steroid most commonly used treatment. There are studies that have shown improvement with systemic steroids, but there are also studies that have shown there is no significant difference by giving systemic steroids. So the natural course is usually the vision worsens over the 2 weeks and stabilizes by 2 months. And spontaneous recovery also is possible in 41 to 43% of the patients. So any progression or recurrence more than 2 months after initial presentation, I should bring would prompt us to question the diagnosis of NAION, and we should reevaluate the patient. So it's basically the control of risk factors, and steroids may be given in patients where the steroid is not is contraindicated, and by monitoring the risk factors. Coming to the arthritic AON, it accounts for 5 to 10% of the anterior ischemic optic neuropathy. As we all know, it is due to the inflammation and subsequent thrombosis of the short posterior ciliary artery caused by giant cell arteritis. The age is very elderly compared to the non-arthritic AON. It is 4 times more common in females compared to males. The ocular manifestation is usually present as rapid onset, marked blurring of vision. The vision will be less than 6/60. Amaurosis figures could be an early sign. Though bilateral involvement is rare, but what we are most worried is about the involvement of the other eye, which can practically leave the patient blind. The typical presentation is a chalky white or pallid disc edema. Coledoretinal artery occlusion, if present, is very specific for arthritic AON because it derives the blood supply from the short posterior ciliary artery. And on FFA, you can see a extremely poor or absent filling of the choroid, suggesting choroidal ischemia. That is another characteristic feature of giant cell arteritis. We should always ask for other systemic features of giant cell arteritis such as headache, jaw claudication, which is pathognomonic of GCA, malaise, loss of appetite, anorexia, weight loss, tenderness that usually patient may complain while combing the hair, polymyalgia rheumatica, pain and stiffness in the proximal muscle groups, and they have non-pulsatile nodular arteries. The most ESR and CRP is a very important investigation. The combination of both ESR and CRP elevation, the ESR will be markedly elevated above 70 and up to beyond 100 even. And combination of both gave the best specificity for the detection of giant cell arteritis. Though normal ESR does not rule out giant cell arteritis. The diagnosis can be confirmed by a temporal artery biopsy. Though we need to at least take a 2.5 centimeter of artery for the biopsy, and it should be serially examined because there could be a phenomenon of skip lesion where there will be areas of inflammation interspersed with the area of normal vessel. And a negative, similarly, a negative biopsy should not prevent us from the ongoing treatment because 15% can have normal histology. And in one biopsy it fails, the chances of other side being positive is 5%. Color Doppler and duplex ultrasonography is another non-invasive technique that is coming up, which shows a hypoechoic halo around the superficial temporal artery lumen in around 75% of the patient, which suggests the edema on the artery wall. The main aim is to prevent the blindness in the fellow eye, and the patient needs to be clearly explained that the prognosis of vision is very bad in the same eye, but our aim is to prevent the blindness in the other eye. We should start them on intravenous methylprednisolone 500 to 1 gram per day for 3 days, followed by oral prednisolone 1 to 2 milligram kilogram per day. And this high dose should be maintained until the ES and CRP normalizes, and the titration is based on the ESR and the CRP. And majority of the patient may need a very low dose steroid lifelong. Tocilizumab is a FDA approved treatment. It can be used for steroid resistant and also can be used as a steroid sparing agent. So in conclusion, the patient need to be counseled regarding the lifelong treatment, and they should adhere to the treatment lifelong, and the steroid therapy need to be started immediately. We may not need to wait for the biopsy report to come because the other eye involvement is the rate of other eye involvement is 54 to 95% in 4 months. Thank you.
Thank you, Dr. Kiran, for that beautiful talk.